Hello, we are group 13 and we are in charge of neurosensory and cerebellar function. In the group, there is Aaliyah, Julia, Octavio, Armando, and me, Na. So for our patient, we have decided the person is JT, who is a 61-year-old male carpenter with a large building firm who is admitted to the Rehabilitation Institute with a diagnosis of right hemiplegia, and dysphagia following a stroke, CVA, 4 weeks PTA. So what is an ischemic stroke or a cerebrovascular accident, also known as CVA? It is a sudden loss of brain functioning resulting from a disruption of the blood supply to part of the brain. He had two main symptoms, which are hemiplegia, muscle weakness on a partial paralysis on one side of the body, and aphasia, which is the loss of the ability to understand or express spoken or written language. So before collecting data from the patient, it's best to be aware of the universal precautions during assessment. So what is the purpose of standard/universal precautions? So the purpose of this stems from the idea that any bodily fluids, including blood, mucous membrane, and non-intact skin, may contain infectious agents that are capable of being transmitted. And for patients and healthcare workers in the hospital, they are at much higher risk for picking up an infection. So the first and most important step to prevent transmission is hand hygiene. You want to make sure you're coming into your patient's room with clean hands. It is recommended you wash your hands before and after every physical interaction with the patients. However, most nurses tend to opt for using an alcohol-based hand sanitizer before and entering the room, and donning clean gloves when they go inside and disposing of the gloves when they exit. But even then, it is important to frequently incorporate hand washing with soap and water into your routine, especially when your hands are physically soiled. Also, it is important to note that you want to avoid unnecessary touching of the patient's surfaces and trying to keep their bedside table clean. So another precaution to keep in mind is use of PPE equipment, also known as personal protective equipment. So the purpose of PPE is to prevent the spread of diseases by creating a protective barrier between the wearer and the contaminated environment. So usually when you interact with the patient, there are times where you will come in contact with their bodily fluids and non-intact skin and whatnot, and you don't want that on you, and you don't want to leave with that on you to not infect other patients. And because of the different type of isolations, there will be different PPEs for each one, and usually they will be listed in front of the patient's room. It usually will look like a type of flyer, like the images on the left. The more common ones in the hospital units tend to be standard, contact, droplet, airborne. Those ones, they all have different types of PPE. So it is important to check all of that before entering the room. Another universal precaution to keep in mind of is respiratory hygiene and cough etiquette. So you want to ensure that your patient is covering their mouth and nose when they are coughing and sneezing, because that can very easily spread germs. And even if your patient isn't in there for like any type of like diseases or infectious things, airborne infectious reasons, you still want to be making sure to remind your patient to cover their nose and dispose of the tissues in the proper bin. And then another precaution to keep in mind of is sterility and proper care of sharp instruments. You want to make sure you're sanitizing equipment that is used and shared between patients. So like for the ACCU check, you would want to make sure that the glucometer is being sterilized between each patient use. And you want to be sure to dispose of sharps in proper label bin, because careful handling of contaminated sharps can prevent injury and reduce the risk of infection.
Okay, so after reviewing the admitting diagnosis for our patient JT, we would ask questions on the following topics to collect our subjective data. So we would ask him about headache, head injury, dizziness/vertigo, seizures, tremors, weakness and coordination, numbness or tingling, difficulty swallowing and speaking, patient-centered care, and environmental/occupational hazards. Next, please. Okay, so because our patient JT has the speech dysfunction, his health history is provided by his wife. So keep in mind, she doesn't know exactly everything, because again, only he knows what he feels. So some of this is a little abroad. But we would ask if he has any usually frequent and severe headaches, and his wife responded yes. He said there were severe or sudden and severe headaches. Then when did they start and how often do they occur? About 2 days ago is when he first told me. He said usually in the morning and they go away by lunch. And where in your head do you feel these headaches? And his wife is unsure. So for head injury, we would ask, have you ever had a head injury? And his wife doesn't know of any head injuries, but if the patient does respond yes, we would also ask, what part of your head was hit? Did you have a loss of consciousness? For how long? And do you remember any details of the event? Now for dizziness and vertigo, we would ask, have you ever felt lightheaded, like a swimming sensation, or feeling like you were going to faint? His wife responded that she doesn't know of any of this, but again, if she said yes, we would ask, when did you first notice this? How often does it occur? How often does it occur? Do you feel like the room is spinning, or are you spinning? And have you ever felt the rotational spinning sensation called vertigo? Next, please. Now for seizures, have you ever had any seizures? And his wife said that she's never heard of any seizures, but we would ask the following: when did they start? How often did they occur? When your seizures start, do you have any warning sign before they occur? Where in your body do the seizures begin? Do they travel through your body on one side or both? Does anything seem to bring on these seizures, like activity, discontinued medication, fatigue, stress? Do you take any medication? And how have the seizures affected your daily life or occupation? Now for tremors, any shakes or tremors in the hands or face, and when did they start? And his wife responded, no shakes or tremors in the hand or face, but we would further ask questions if yes, like, do they seem to grow worse with anxiety, intention, or rest? Are they relieved with rest, anxiety, or alcohol? And do they affect your daily life? Now for weakness, we would ask, any weakness or problems moving any body part? His wife responded, following the stroke, he's not been able to stand and walk without assistance. He is able to move his left leg, but not his right one. And we would further, we would further ask if it was generalized or localized, and does weakness occur with any particular movement? But since his wife doesn't know, we didn't ask. Next, please. Thank you. Now we asked about coordination. Do you have any problems with coordination? His wife responded, yes. He's unable to keep his right side of the body balanced. His left side of his body is not affected. Then we would ask any following, like, do you list to one side? He does list to his left side because it's the side that's not affected. And do you feel clumsy? Yes, he is unable to hold himself up. Now for difficulty swallowing, we would ask any problem swallowing. The wife responded that he does have issues swallowing. Does it occur with solids or liquids? And she responded both liquids and solids. Have you experienced any excess saliva or drooling? And yes, she has been drooling, or he has been drooling more frequently, according to his wife. And for difficulty speaking, any problem speaking? And his wife responded, yes, he has trouble speaking. He's only able to speak small words very slowly. It takes a lot of energy for him to even say one word. Is it with forming words or with saying what you intended to say? His wife responded, forming words. When did you first notice this? His wife responded, right after he woke up in the hospital from his fall at work or the stroke. How long did it last? It is still ongoing, according to his wife. Next, please. And now we would ask about numbness or tingling. Any numbness or tingling in any body part? His wife responded, I'm not sure if he has any numbness or tingling. Now for patient-centered care, we would ask about history of stroke, spinal cord injury, meningitis, encephalitis, congenital defect, or alcohol use problem. His wife responded, not anything that I know of. And we would also go on to environmental/occupational hazards. So we would ask, are you exposed to any environmental/occupational hazards, including insecticides, organic solvents, lead? His wife responded, no. Then we would ask, are you taking any medication now? And his wife would respond, he's taking his stroke medication now. I don't remember what it's called, but it's twice a day. We would further ask, how much alcohol do you drink, and per week, per day? His wife responded, no alcohol. And we'd ask about any mood altering drugs. And his wife responded that he does not take any drugs.
So when you do a neurological assessment for a patient, there's an order in the way that it is performed. First, we assess the patient's mental status. So for example, that'd be like the level of alertness. And then we would check for the cranial nerves, so that would be like they would be testing their facial strength and their eye movement. And then nextly, you move on to motor systems. So like the patient would be asked to either abduct or flex different parts of their body and see if it's like coordinating well, like their fingers. And then after that, you would check the sensory system. So you would see how they react to pain and temperature and like light sensations. And after that, you would move on to reflexes. So you would check their reflexes and like their responses. Next. But before we start to assess our patient, we need to gather some equipment. Most of these you probably have already seen or heard about, so I won't elaborate on most of these too much. However, the ophthalmoscope might be uncommon equipment for a handful of people in this class, or I mean, it was for me. So to explain what it is, it's basically an instrument that allows the provider to view the back of the eyeball using light and different tiny lenses. Its main purpose is to allow the provider to look at the health of the retina, optic nerve, and other eye structures.
So for the neurological, sensory, and cerebellar function assessment, the overall goal of this assessment is to thoroughly assess the cranial nerves. So that's cranial nerves 1 through 12. You want to test cerebellar function and test the overall sensory system, which includes the anterolateral and spinothalamic tract and the posterior column tracts. And it's important to note that this assessment focuses primarily on inspection, and it's also important to consider age and developmental stages, as well as how alert and able your patient is to answer these questions. So for the cranial nerves assessment, you want to start off with cranial nerve number 1, which is the olfactory nerve, which is not tested routinely, but can be tested for those that report issues with their smell or have had head trauma or an abnormal mental health status. It also is tested when the presence of a cranial lesion is suspected. So to test this, you would pinch or block one nostril while the patient's eyes are closed, and then have the patient smell an aromatic substance such as coffee, vanilla, or cinnamon. Cranial nerve 2, or the optic nerve, it tests the visual acuity and visual fields by confrontation. And to do this, you would place your finger in front of your patient's eyes and have them follow the 6 cardinal points. And you could also use an ophthalmoscope to examine the ocular fundus to determine color, size, and shape of the optic disc. As for cranial nerves 3, 4, and 5, the oculomotor, trochlear, and abducens nerves, you want to check for pupil size, regularity, equality, direct and consensual light reaction, and the accommodation, so PERLA. And you want to assess extraocular movements by the cardinal positions of gaze, which can also be tested in the last cranial nerve. And you want to assess for nystagmus. For cranial nerve 6, the trigeminal nerve, you want to check both the motor and sensory function. So for the motor function, you want to assess the muscles of mastication or like chewing. So you would have the patient clench their teeth and palpate the temporal and masseter muscles. And for sensory function, you would test the light touch sensation by touching like a piece of cotton ball or cotton wisp to multiple areas of the patient's face, such as their forehead, their cheeks, their chin, and have the patient identify where they feel that particular sensation. And you would also assess the corneal reflex if the person has abnormal facial sensations or facial movement abnormalities. For cranial nerve 7, or the facial nerve, you also want to test motor and sensory functions, although the sensory function isn't tested routinely. For the motor function, you want to assess mobility and facial symmetry. So you would ask the patient to perform certain movements such as puffing their cheeks, pressing in the puffed cheeks to see if air escapes equally, and have the person frown and smile as hard as they can. And for sensory function, again, you would only test this if you suspect a facial injury. So when indicated, you want to test the sense of taste by applying a cotton applicator covered with a solution of something like sugar, salt, or lemon juice, and you would ask the patient to identify that taste. For cranial nerve 8, the vestibulocochlear nerve, you would test the hearing acuity by the ability to hear normal conversation. So you would use the whisper test, and you would whisper like a sequence into an uncovered ear. So you'd have a patient cover one ear, and then you'd whisper, and then you'd have them repeat it back to you. Of course, this is a consideration with our patient because he can't respond verbally, so you'd have to find other ways to test this. For cranial nerves, for the glossopharyngeal and vagus nerves, you also have to test motor function and sensory function. So you would use a tongue blade, and you would depress the tongue, have them say ah, and examine the pharyngeal movement for the uvula and the soft palate, and they should rise in midline. And you could touch the posterior pharyngeal wall with a tongue blade and note the gag reflex. Of course, this is not very comfortable for your patient, so you want to make sure you make this quick and assess it as thoroughly, but also without making your patient too uncomfortable. And here, the voice should sound smooth and not strained. For a sensory function test, the cranial nerve does not mediate taste on posterior 1/3 of the tongue, but so it would be generally too difficult to test. So for cranial nerve 11, the spinal accessory nerve, you would examine the sternomastoid and trapezius muscles and check for equal size. Check for equal strength by asking the person to rotate their head against resistance. So you would apply resistance to their chin and then have them try to move it against your force. And then you could also ask the patient to shrug their shoulders against resistance. So you'd have your hands on top of the patient's shoulders and have them shrug. And finally, for cranial nerve 12, the hypoglossal nerve, you would inspect the tongue, and check for no wasting or tremors. You would also note the forward thrust in the midline as the person protrudes their tongue, and you could ask the person to say words like light, tight, dynamite, and note their lingual speech. So for the cerebellar function assessment, you would test the balance. So that includes gait, and you could just observe the person walking 10 to 20 feet and turning and returning to a starting point. And you could also do tandem walking, which would be asking the patient to walk in a straight line in a heel to toe fashion. And as for Romberg sign, you would ask the patient to stand with their feet together, arms at their sides. And then when they're stable, you'd ask them to close their eyes and hold the position for 20 seconds. And you want to make sure that you are next to them in case they fall. And you could also ask the patient to perform a shallow knee bend while standing, or you could have them hold the table, or even ask the patient to hop in place on one leg and then repeat with the other. You could just test this with your nursing judgment to see like if you need one test or the other test. You don't have to perform all of them if you don't see any abnormalities. So for the anterolateral or spinothalamic tract, the patient's eyes should be closed during all these tests. So you would be testing pain, light touch, and temperature. For the pain assessment, you would break a tongue blade or find some kind of sharp-ended item and also a dull-ended item. And then you would apply these two, sharp and dull, to other areas of the person's body, and you would ask them to respond if the feeling is sharp or dull, and also ask them to name where they feel the sensation. For the light touch, you would touch a piece of cotton to the patient's skin, and this should be done at random intervals to different areas of the patient, including all over the body, like arms, forearms, chest, hands, thighs, legs, and you can have the patient respond now or yes, or give a thumbs up whenever you feel something. And as for temperature, this can be omitted if the pain sensation is normal, and it's performed the same way as a pain test, except with warm and cold water. And you want to, for all these tests, compare symmetric points on the body to see if the sensations are felt properly. And finally, for the posterior or dorsal column tract, you want to test for vibration and position or kinesthesia. For vibration, you want to test the patient's ability to feel vibrations using a tuning fork over bony prominences. So you'd strike the tuning fork on the heel of your hand and hold it over a bony surface of the fingers and the big toe and have the patient report when the vibration starts and stops. And for kinesthesia, you want to test the patient's ability to perceive passive movements of the extremities. So you'd have the patient close their eyes, and you would move their finger or big toe up and down and ask the patient which direction it's moved and just have them identify it. And then for the dorsal column tract, you want to always check for bilateral comparisons. So for posterior dorsal column, for these tests, patients should have their eyes closed. For the fine touch tests, you want to test stereognosis. So you have the patient close their eyes and you can place like a familiar item into their hands and ask them to identify it. For graphesthesia, this is the ability to read or identify a number as it's traced into a person's skin. So you would trace like number 3 into the patient's skin on their back or their hand and have them identify it with their eyes closed. For extinction, you would want to touch both sides of the patient's body at the same point. So like both their cheeks, both their arms, and ask the person to state how many sensations are felt and where they're felt. And finally, for point location, you want to touch the patient's skin and then withdraw the stimulus immediately. So just kind of like a light touch or a poke, and then you would ask them to identify where you touch them. And this can be performed together with the light touch sensation test.
Okay, Julia, thank you. So the next part is going to be, once we get through the scenario, we got our signs, we got our symptoms. This is what a normal finding would look like, and then what the abnormal findings of JT look like as well. So let's go through. Next slide. So now that we have completed our health assessment, let's talk about JT's abnormal findings and then compare those with the normal ones. If we take a look at the top center picture, it represents the normal reflexes and motor strength of a healthy person. And then we would expect no atrophy, no weakness, no tremors. Agile movements such as the finger to nose exercise. Gait should be smooth and coordinated. The person should be able to do a tandem walk, as we mentioned earlier. And this is just that heel to toe forward and back. And we would expect a negative Romberg if we were to do that test, and that would tell us that his balance is good. So if we tested a healthy person's reflexes, we would see no Babinski signs, and we would see no deep tendon reflexes. Those should be +2, equal, bilateral, and then the toes should move downward, if anything. Now let's take a look at the other side. If you notice that the centered image below, the right foot has a upward pointing arrow, and the articulations show a +4 instead of a +2. So that tells you that there's a hyperreflex. The right abdomen is also depicted as 0 for being unresponsive. And the articulation and the reflexes on the right are reported to be hyperactive with clonus, which is involuntary rhythmic contractions. So as for motor function, JT's right leg and his right hand grip are weak. His right arm drifts and he's unable to support his weight at this time. As expected with his right side, there's hyperactivity, which is noted on the homunculus there. His right arm and leg are spastic, and he has a limited range of motion, even with passive movements that we can help him with. In a finger to nose test, his right side fails while his left side is smooth. So taking a look at the table, let's go ahead and maybe move to the next slide. So yeah, we would determine that JT's injuries resemble an upper motor neuron lesion versus a lower one. Why? Well, for one, the stroke is the most obvious case of an upper lesion, being that the brain is the highest anatomically in the neuronal pathway. But we also talked about muscle tone, which is spastic versus atrophied, and you can see that on the chart there in the middle. And additionally, we have no reports of fasciculations, which is like fine muscle twitches. And we have positive sign of a +4 hyperreflexia and the ankle clonus, which was listed on the little sheet there with the little man. Next slide. So moving on to mental status, a healthy 60-year-old male would have a proper dress and appearance, behavior, and speech. So he would be alert and oriented to a person, place, and time, and his short-term memory would be mostly intact. Now, in JT's history, we have him arriving in a jogging suit, and he's in a wheelchair. So he made appropriate eye contact, and he listens well, but his speech is slow, difficult, and monotonal, the one-word responses. So depending on where he was coming from, his outfit might or might not match a normal expectation. If he was coming from work, the tracksuit doesn't make sense, right? Now, what we would be alerted to would be the wheelchair, obviously, and particularly his that he's in a wheelchair, but he has normal level of cognition. So this combination just leads us to believe that the problem is not psychological, but neurological, or possibly like medical, like trauma. Next slide. So let's talk about normal sensory findings and the abnormal sensory findings. So we can confirm that we have a neurological problem, but he has that diminished light touch sensation on his right leg and his right arm only. And his sense of position is also impaired unilaterally, so just that one side. So otherwise, a normal sensory assessment would show that equal, clear, and then bilateral sensation. He would feel sharp, he would feel the dulls, like touch, vibration from the different tests that we did. That would be stereognosis is intact, and the ability to determine the shape of objects. So stereognosis is just if my eyes are closed, can I feel like what the shape of a rectangular thing would be, or a circular thing would be, right? If my eyes are closed. So let's move on to the next slide. This is the review of like the cranial nerves, which we've gone through enough. So let's just kind of like focus on the abnormals that we have from JT. So we know that anticranial nerves should be able to perform. So through a confrontation test, for example, we know that he has good acuity, but we also found that he has that right homonymous hemanopsia. So that means that half of his vision is impaired from the right side of each eye. So from this field, on the side, both eyes, his vision is impaired. Now, from testing the trigeminal nerve, we know that his jaw strength is lacking on the right side, as we would have expected. Next slide. From looking at nerve 7, the nurse noticed that JT's right nasolabial fold was flat, meaning that his facial muscles are flaccid, such as in that facial droop, and he could not produce proper movement. So he was able to wrinkle his forehead bilaterally, but he was unable to smile or bare his teeth on the right side. We also found that his head movement was more diminished on that right side. Now, that's it for JT, right? But for the point of this lesson, let's go on to that next slide and just cover some other abnormal movements that maybe JT doesn't have, but if we see it, we should be able to know that, that's abnormal, that's weird. So we have, maybe not in this case study, but we have myoclonus, paralysis, tics, fasciculations. Myoclonus are those strong twitches, such as a diaphragm. When our diaphragm has myoclonus, it's a hiccup. In a grand mal seizure, myoclonic jerks might be harmful. So there's something to look for if a person is seizing. Fasciculations, as we mentioned earlier, are those like fine muscle, those muscle twitches. If you guys want to Google real quick, Katy Perry fasciculations, creepy. Now, next slide. And these are just other movements to consider. Chorea, those are non-rhythmic and random movements that are stronger than a tic. Athetosis is an involuntary twisting or writhing movement which occurs at the distal ends of extremities. Rest and intention tremors. So just to differentiate those, one occurs continuously, such as the first, and then one only happens when the patient is trying to will a movement, which is the second one. An intention tremor can signal a cerebellar disease, such as multiple sclerosis, while it could also be benign when you're past a certain age, versus the case of a tremor that happens when you're at rest, and a provider can begin to suspect like Parkinson's, for example. So thank you for your attention. I'm going to hand it off to Octavio.
Today I'll be talking about the different variations for age. First I'll be talking about infants. So infants, their neurological system is not completely developed at birth, and their motor activity is usually under control of the spinal cord and the medulla, and their neurons are not yet myelinated. Their movements are extremely primitive and basic, and they require very strong sensation. For an infant's sensory motor development, it corresponds with myelination, and there are usually set milestones that the infants have to achieve. So when assessing an infant, you want to note the milestones expected for each month, as well as the eventual disappearance of primitive reflexes. You also want to observe spontaneous waking activities, their response to the environment and social interaction. So when you're assessing the cranial nerves for an infant, they cannot be tested directly, but you can infer their function by using certain maneuvers. So for cranial nerves 2, 3, 4, and 6, you can do the optic blink reflex, as well as noting the size, shape, equality of the pupils, as well as whether the eyes follow movement or not. For the 5th cranial nerve, you can use the rooting and sucking reflex. For cranial nerve 7, you can note whether its facial movements are symmetric. For cranial nerve 8, you can test it using the Morrow reflex or the acoustic blink reflex. For cranial nerve 9 and 10, you can use the swelling gag reflex. And for cranial nerve 12, you can pinch the infant's nose and their mouth and see whether their tongue rises midline. So for the motor system of an infant, you want to observe for smoothness and symmetry, as well as developmental milestones. You also want to check for spasticity, which is stiffness of muscle or abnormal muscle tone. Usually at about 3 months, the fist of the infant starts to open. At about 4 months, infants can reach for an object purposefully. At around 7 months, they can transfer an object hand to hand. At 9 months, they can grasp objects with their fingers and their opposing thumbs. At 10 months, they can purposely release an object. And at 18 months, they're usually ambidextrous. Head control is a very important milestone in motor development for infants, and it is assessed with 2 techniques. The first is holding the baby supine and then pulling them to a sitting position by holding their wrist. A second technique is lifting the baby in a prone position with one hand supporting their chest. And here are some major infant milestones. Usually milestones and myelination follows a cephalocaudal and proximal distal order. The first will be lifting the head and shoulders. The second will be lifting their neck. The third will be rolling over their trunk. The fourth will be moving their entire arms and legs. The fifth will be utilizing their fingers and toes. And the sixth will be walking. So for the sensory system of an infant, you want to assess infantile automatisms, which are reflexes that have a timetable of appearance and departure. These reflexes include the rooting reflex, the sucking reflex, the palmar grasp, the plantar grasp, the Babinski reflex, the tonic neck reflex, the Morrow reflex, the placing reflex, and the stepping reflex. And here are just a few pictures of the different reflexes that you can assess on an infant. And so variations for preschool and school-age children, you want to assess general behavior during play activities, their reaction to their parents and their cooperation. You also want to note their gait during both walking and running. You also want to observe how the child rises from a supine position. You also want to do the finger to nose test with their eyes open and their eyes closed. You want to test sensation, but it's very unreliable in toddlers and preschoolers. Generally, deep tendon reflexes are not tested in children younger than 5. And if a child is feverish and irritable, you want to test for nuchal rigidity. For aged adults, usually atrophy or degeneration of neuron structure in brain is evident. There's also a decrease in weight and volume with thinning cerebral cortex, an expansion of ventricles in brain, and reduced subcortical brain structures. Usually neuron loss in aged adults leads many people older than 65 years to exhibit signs that are abnormal in young adults. These can include general loss of muscle bulk, loss of muscle tone in face and neck, decreased muscle strength, and impaired fine coordination and agility. There's also an increased risk for Alzheimer's disease in aged adults. 10 warning signs of Alzheimer's in aged adults are memory loss, losing track, forgetting words, getting lost, poor judgment, abstract failing, mood swings, losing things, personality change, and growing passive. Also in aged adults, the velocity of nerve conduction decreases between 5 to 10% with aging. There's also an increased delay at synapse, so there's a longer time for impulses to travel. They also have a slower motor system, and there's also a progressive decrease in cerebral blood flow and oxygen consumption. Aged adults also have decreased muscle bulk. They also have senile tremors, which are usually benign and often occur with intention. Aging adults may have difficulty performing rapid alternating movements, such as pronating and supinating the hands on thighs. And after 65 years old, loss of sensation at ankle malleolus and loss of ankle jerk are common. And also deep tendon reflexes are less sharp and active. For ethnicity, usually a neurological disease that varies between ethnicity is a cerebrovascular accident or stroke. A stroke is defined as an interruption of blood supply to the brain, and there are two types, ischemic and hemorrhagic. An ischemic stroke is caused by blood clot that blocks blood vessel and brain, and it accounts for about 87% of all strokes. A hemorrhagic stroke is when there's a ruptured blood vessel that bleeds into the brain. And there are different variations in terms of ethnicity and who experiences stroke. So for African Americans, American Indian, and Alaska natives, as well as Asian and Pacific Islanders, they tend to die from stroke at younger ages than do whites. African Americans also have 2 to 3 times the risk of stroke as whites between ages of 45 to 64 years old. 40% of stroke risk in African Americans is due to having high risk for traditional stroke factors. Hispanic and Asians are also much less likely to use emergency medical services than whites, and Black women are less likely to use emergency medical services than are white women. And some variations for gender. There's a higher prevalence of unprovoked seizures or epilepsy in males than in females. Females have an increased risk of multiple sclerosis, but males face a harsher disease course. Females have a higher prevalence of Alzheimer's disease than age-matched males. Amyotrophic lateral sclerosis, which is also known as ALS, is more common in males than females. And males are more likely to develop Parkinson's disease with a ratio of 1 to 6. And that concludes our presentation. Thank you.